All right. Well, we'll go ahead and get started with today's AMSSM Sports Ultrasound Case Series presentation. I have the pleasure of introducing Dr. Drew Duerson. He's a sports medicine physician at Nationwide Children's Hospital in Columbus, Ohio. He serves as an associate program director for the fellowship and is also a co-director of the musculoskeletal ultrasound program within the Division of Sports Medicine. He's a clinical assistant professor of pediatrics at The Ohio State University, and he's certified in musculoskeletal sonography and point-of-care ultrasound. He's also been the director of multiple pediatric musculoskeletal ultrasound workshops and is an active member of national organizations, including the Alliance for Physician Certification and Advancement, Pediatric Research in Sports Medicine, AIUM, and the AMSSM Ultrasound Committee. And today he's going to be presenting on proximal humeral epiphysiolysis for us. So thanks again, Drew, for giving this presentation.
There we go. Like you said, my name is Drew. I'm presenting today from Columbus, Ohio and Nationwide Children's Hospital. It's a privilege to join this outstanding AMSSM webinar series again. I'm particularly excited about today's topic being pediatric specific. I think this will fit perfectly with some of the other topics within this great collection that have focused on the young athlete. So without further ado, let's dive into some ultrasound evaluation of proximal humeral epiphysiolysis and hopefully show how point-of-care ultrasound can make a real difference in your clinics. There we go. Before we start, no disclosures. These will be our objectives, which should be familiar to the regular attendees watching. I'll try to stick to this roadmap as best I can, but there'll be a few detours as I try to highlight some of the unique aspects of pediatric musculoskeletal ultrasound. My goal is to share some practical material with you all that hopefully sparks some discussion that's ongoing so we can continue to learn together about these topics and hopefully give you some tools that you can start using as soon as tomorrow in clinic. We'll start with our case. This was a recent case of mine. This is a 11-year-old male right-handed baseball athlete that presented to my pediatric sports medicine clinic. He had insidious onset shoulder pain for about a month. It was worse in the last 2 weeks. It was first thought to be some soreness after pitching, and now it progressed to more significant pain with really all throwing. He also noticed that his speed and control had declined. No pain with batting or other parts of the sport. It was just throwing. Denied any acute trauma to the shoulder. Had some mild weakness. No popping, clicking, instability. No catching, locking. And on exam, really only had some mild tenderness to palpation at the lateral shoulder. Full range of motion. Did have a little bit of pain with active overhead motion. Full strength. Negative special testing, so no impingement signs. Rotator cuff labral or instability testing was all negative. So at this point, like most of my patients, I'm starting to think about how can I use point-of-care ultrasound to help me confirm my diagnosis, maybe rule out some others, or at the very least help with my physical exam and explain the pathology to my patients and parents. So typical in our clinic, we start with radiographs, and this is often before we even see the patient. Here we have our standard 3-view series of the shoulder. So if you're not familiar with the immature anatomy or you don't have that contralateral comparison readily available, it would be easy to call this set of radiographs normal. And I think this is where ultrasound can play a big role. So I always ask, point-of-care ultrasound help me reach the diagnosis, or at least provide some clarity and reassurance to the family. And I think in pediatrics, the answer is often yes. So instead of sending the patient back to the radiology tech to get a contralateral x-ray, which is going to cost more, take more time, and add more radiation, I'll often turn to ultrasound in these scenarios. So here's the list of pathology from AMSSM's recommended curriculum that we try to teach our fellows. And for the pediatricians watching, you'll know that we likely don't see a lot of this pathology. There may be a few on the list, and there may be some that we see rarely, but I would argue most of the common pathologies that we see, and like we'll find out in this case, they've been left off this list. And these are diagnoses that can be easily confirmed with point-of-care ultrasound, and I'd say especially so when radiographs are not readily available. So this is our shoulder scanning protocol today. This will be likely familiar to you all, but I've highlighted some structures that are particularly important in the skeletally immature shoulder. And I would encourage you to start looking for these and try to add them to your protocols when you feel like they're clinically indicated. And before we start looking at images of our patient, I wanted to quickly review the normal sonoanatomy of ossification centers, because we'll be talking about that throughout the presentation today. So we'll start with the unossified cartilaginous epiphysis. So this will be at the end of the long bone. This is usually going to be hypo or anechoic. It can have a stippled appearance, and that's going to be seen in the youngest patients. This stippled appearance is the result of normal vascular channels that you see in that growing epiphysis. The key here is you can definitely mistake this for pathology, and the epiphysis can mimic joint fluid or synovial hypertrophy. So you want to be able to differentiate them from each other. And the apophysis, which is going to be nearby but not on the weight-bearing surface, is going to have a similar appearance where it's going to be hypo or anechoic. And again, you want to not mistake this for effusion or synovial hypertrophy, because it very much mimic that. And you want to pay attention to the soft tissue changes associated with the apophysis, because that's how often we're going to make our diagnoses of apophysitis. Then we have secondary ossification centers. These are found throughout the body. These are going to be echogenic structures within the epiphysis. This can mimic a loose body, so you don't want to make that mistake. And then the underlying bone that's growing is very irregular, and that can be mistaken for an erosion too. And then lastly, our physis. This will be that focal discontinuity that you find at the metaphyseal epiphyseal junction. This is going to be very vascular and irregular appearing. So when we're looking at this, you want to make sure that you're comparing to the contralateral side, and you'll hear me say that a lot today. So that's just normal sonoanatomy of ossification centers, and if you're not familiar with them, the more you look at these, the more familiar you'll get. All right, so we'll start at our home base, and this will be the long head of the biceps tendon. So in short axis, we'll try to find it between the greater and lesser tuberosities, and this is going to look a little bit different than what you're familiar with if you look at mostly adults. As we scan in short axis from proximal to distal, we'll see that bicipital groove lies just proximal to the physis, so that bone underneath is going to look very irregular as you scan. And then we'll keep scanning down until we see the musculotendinous junction, and that's where we're going to find the pectoralis major tendon overlying in long axis. And then from there, we'll rotate and look at the biceps tendon in long axis, and that will now put the pectoralis major tendon in short axis. And as you can see here in the picture, it's a relatively elongated structure and can be described as a cigar shape. And then as we move just medial to the long head, we'll get the short head of the biceps and the coracobrachialis. And from there, we're going to follow that short head of the biceps and coracobrachialis proximally. And these will often form a conjoint tendon, though variants do exist, so you got to be careful. And then at the coracoid, that's where we'll end, and that's going to be our first pediatric landmark. That's going to be the coracoid apophysis. So at the apophysis, we're going to look for asymmetry, irregularity, fragmentation, separation, and avulsions. And then in our case here, this was normal. And if a patient is having pain around the coracoid, I'll often then look at the pectoralis minor. So you're just going to rotate that distal end medially and get oblique over top of the long axis image of the pec minor. And then in this case, we did that, and we see the brachial plexus deep. And then we'll abduct the shoulder and look for any superficial bowing of that pectoralis minor. In this case, the patient had a normal exam. So a few companion cases that I'll go through quickly. This is a 13-year-old that had shoulder pain for over a year, had seen multiple providers, had multiple radiographs, MRI, even had a diagnostic arthroscopy. And despite all that, the diagnosis was still missed. And with a quick ultrasound and a contralateral comparison, I was easily able to identify this small coracoid avulsion fracture. And while it seemed like clinically that was the pain generator, we did a easy diagnostic injection and confirmed that was truly the case. So after months and months of misdiagnosing, we were able to finally make that with a quick, easy point-of-care ultrasound. Here's a more obvious case. Radiographs revealed this displaced avulsion fragment in this 17-year-old male gymnast that had an acute shoulder injury months ago. But he really came in to see me after he'd had chronic intermittent symptoms of clicking and popping. And with this dynamic ultrasound, we see that that avulsion fragment was quite displaced laterally and was sitting right on top of the subscapularis. And with some rotation of the shoulder, we could easily recreate the popping and clicking that he was experiencing. So again, we can look at the coracoid apophysis and look for anything from apophysitis all the way to displaced avulsion fractures like this. So now the first rotator cuff muscle that we'll get to, that's the subscapularis. This video will show a short axis sweep from medial to lateral. And I like doing this because it will really show me the multiple muscle bellies of the subscapularis. And this really explains why we see those multiple tendon slips when we're looking at the tendon and short axis. And while rotator cuff tears are, very rare in kids, I've seen some acute myotendinous injuries, and in particular, I've seen some inferior subscapularis tears, and we're able to identify that on ultrasound. So I think it's important to look all the way back to that musculotendinous junction, try to see these 3 or 4 muscle bellies, and realize there could be even more studies up to 9 muscle bellies. So you know there's going to be some variability there. And then once we are able to follow that all the way out to its tendon, we will turn and look at it in long and short axis. And again, we can see those multiple tendon slips, and here long axis image of the subscapularis tendon. And we'll see this with all the rotator cuff tendons today, but they're going to attach to unossified cartilage here. So it's going to look much different than your adult patient where you're going to attach to that nice, smooth cortical facet. So you got to be comfortable seeing that. And then dynamically, we'll assess the subscap with some rotation. And in this case, we see smooth motion of that muscle and tendon beneath the coracoid with really no impingement. So really quickly, I think one of the early challenges that I had was differentiating fluid that was coming from the subcoracoid bursa from the subscapularis recess. And this reference was really helpful for me, so I wanted to share it. And these videos will show this. So this is going to be a transverse image. We can see the subscapularis there rotating. This first image is going to be the bursa. So this is going to be less common, but this is typically going to be differentiated from the more common recess because it's often larger, can be very irregular shaped, and can be compressible and deformable. As you see in this video, it's changing shape. And that will differentiate itself from the more common recess that communicates with the joint. So if we have an effusion, we'll often be able to identify this. But this sits kind of in a similar position, but it's more ganglion-like, so not really going to change its shape as we rotate the shoulder. So you don't want to mistake one for the other. So just good paper. Maybe, fellows, if you get a chance, try to take a look at that one. All right, so we've dynamically assessed the subscap. Now we can just slide laterally back to that home base, the bicipital groove, and check for biceps instability. And I'd say in pediatrics, this is very, very uncommon. I don't know if I've seen this in a kid, but we'll take a quick look at it. And I think, we don't see it because we're not seeing those significant subscapularis tears. So take a quick look, but don't expect to probably find much instability there in a pediatric patient. All right, so next we go to the AC joint. So we'll pay close attention to the lateral clavicle here. So AC sprains, I think, are often misdiagnosed when the real issue is a Salter-Harris fracture. So you want to pay close attention to that lateral clavicle. And that physis stays open sometimes into early 20s. So this can be something that you can see throughout adolescence into college. And you also can appreciate that the acromion here is mostly unossified. So you don't want to mistake this for joint widening or effusion. So you want to try to find the edge of that unossified acromion and not make that mistake. And then dynamically, this video shows a stable AC joint during shoulder adduction. So simply just ask the patient to touch their opposite shoulder. And we're looking to see usually if that clavicle goes superficially or if that space widens. And in this patient, it was unremarkable. So from the AC joint, we now will slide laterally and slightly posterior to find the acromial epiphysis. And this video will show that. This is going to be the attachment site for the deltoid and the coracoacromial ligament. So in overhead athletes, we can see epiphysitis here due to those opposing forces that are pulling on it. In this case, the patient's epiphysis was normal. And then like all these epiphyses, we want to check Doppler and look for hyperemia. And in this case, it was relatively quiet in that box. Here's a companion case. This is a 12-year-old overhead athlete that localized their pain to the acromial epiphysis. But I show this just to show how subtle this could be. When you look at the physis or the epiphysis, you can see that there's just some very slight elevation. And then when we look with Doppler and compared to the contralateral side, it's just some very minimal hyperemia. So it can be pretty subtle. So I think you look for these findings, but also just use sonal palpation to localize the pain right over top of that epiphysis. And then here's another case. This was a little bit different. This was a direct fall on the shoulder and had pain right at that epiphysis. And again, really just relying on sonal palpation to help make that diagnosis. And then our contralateral comparison, we can see that there's some hyperemia on the symptomatic side. All right, so now we move lateral to the acromion. We get to the supraspinatus tendon. Unique to skeletal immature shoulders, you can often see through the acromion and see the majority of the supraspinatus tendon. But I still think it's a good skill to learn the modified CRAS position, which will be in this image here. It's flipped, but now we can see the tendon all the way back to the musculotendinous junction. And I think this is one of those key things to practice with the shoulder exam, often one of the more, I think, challenging parts of the shoulder exam. So for me, it's get them in the modified CRAS positions, usually it's side lying, hand on their back hip, elbow kind of force toward the ground with gravity. And then I just take the transducer and go straight to the anterior shoulder. And I will point the proximal end towards the patient's ear. And usually if you do that, you'll fall pretty close to where that supraspinatus lives. So again, fellows watching this, that will be a skill I would highly recommend that you guys practice. All right, and then the acromial subdeltoid bursa, as we know, this sits between the supraspinatus and the deltoid. So you're going to look for two hyperechoic layers of bursal tissue and fat. And then in this patient, you can just see a very normal, fine trace amount of fluid here in the rotator interval. It's going to be even hard to point out. It's going to be sitting right here. And then as we slide a bit laterally over where the supraspinatus and infraspinatus overlap, we can again see a little bit of fluid in that bursa, and that was just normal. And this just demonstrates how big that bursa really is. And then I was guilty of this early on, but don't forget the coracoacromial ligament. I think it's very important, especially in our young patients. This is often where I find they localize their impingement symptoms too, more so than the acromion. So I will dynamically assess this area with shoulder abduction. As we'll see in this video, this patient had some minimal amount of bursal fluid that you'll see pop in and out of the video there. But I think most importantly, we have a nice normal ligament going from coracoid over to that unossified acromion. And we can appreciate that that ligament stays nice and flat, and we don't see any superficial bowing with that overhead motion. And then under the acromion, we kind of see that classic impingement site where we'll take another video and see some smooth tendon gliding, no bursal distension, no tissue bunching, so this looks normal. All right, so now we've landed to our key landmark here finally. So the proximal humeral physis. So I try not to start here where the pain is in this case. Seems to be most prominent because I think a routine, as we've heard multiple times on this case webinar series, really can help ensure completeness so you don't miss things. So when I get to the physis, I'm going to look for the widest portion of the physis, and that's often going to correlate where the patient's having maximal pain and tenderness with sonal palpation, but that's not always the case. So you want to scan the full width of that physis and try to find the widest area. And then what's really key here is you got to do a contralateral comparison, because if not, you won't really be able to make this diagnosis that easily. And you're going to try to shoot for a near perfect match when you're making that comparison. So you're going to look at the bony contours, but maybe even more importantly, look at the soft tissue echo textures over top and that deltoid muscle. And you're going to want to try to find the exact same picture on the contralateral side so you can make a nice comparison. And then you're going to want to use Doppler. In this case, this patient had some mild hyperemia of his periosteum and some mild periosteal swelling compared to the contralateral side. But you do got to remember the physis is very vascular, so bilateral comparisons are critical, especially in our younger patients where we can see a lot of normal physiologic flow. And with that being said, I do use power Doppler like I did in this case, but I would say you might consider using more color Doppler in your younger patients, as it's going to be a little less sensitive for that kind of normal slow flow physiologic flow to the physis. And then here are just a few examples from younger patients. So you can see a difference as patients age, things change. So at age 3, down here at the bottom, we can see that epiphysis is very unossified, and we can see that stippled appearance from those vascular channels that I mentioned. And then all the way up to a 9-year-old here, where the epiphysis is mostly ossified, but we're still seeing some kind of irregular growing bone underneath. And that physis is starting to narrow, but we can still see that that's very open and irregular too. So again, just get comfortable looking at all different ages. I think it's going to really help you. All right, and then we'll kind of fly through some case examples of Little League shoulder that kind of go along with this case. So this is a 11-year-old that was similar age to our case here, but more pronounced widening actually. So if you compare the sides, you can see pretty obvious widening of that physis compared to the contralateral shoulder. This is a slightly younger patient with some clear physeal separation. So this would be more advanced presentation of epiphysiolysis. This patient likely had pain for several months and developed that more significant widening. And then I think another useful metric too is physeal depth. So as the physis widens, the ultrasound penetrates deeper. So this allows you to visualize farther into the growth plate. That just makes sense. So I will measure the depth as we did in this picture and compare that to the contralateral side, just as you would with width. So using those two metrics can really help you make this diagnosis. And lastly, here's a 13-year-old, a little bit older, so you can see that the epiphysis here is nearly ossified, but still has the open physis, and you can see that there's some subtle widening of that physis on the contralateral side. So those are just some different examples of Little League shoulder. But a reminder, not every young overhead athlete with the story that we're sharing has Little League shoulder, even though it can seem like that at times. This was a little bit younger patient, but they came in with a presentation that was very similar to this presentation, and I thought we were going to have another case of Little League shoulder. X-rays were red normal, and it wasn't until we did an ultrasound that we found a metaphyseal mass that was just distal to the physis, and that really is where his pain localized. And you can see in the short axis image that mass was pushing right into his long head of the bicep. So again, not every young overhead athlete with lateral shoulder pain has Little League shoulder. All right, so now let's move posteriorly and wrap up here. So we will now look at the infraspinatus. We'll find it over top of the glenohumeral joint. It has this nice central tendon. We'll follow that central tendon out to where it attaches to the middle facet of the greater tuberosity. Again, you can see how it's attaching to unossified cartilage. And we know that the middle facet can have some irregularity underneath the tendon there, and that's normal, and that can be even more so in that growing bone. So don't want to mistake that for an abnormal erosion or cyst. And then to find the teres minor, which sometimes is a little bit tricky, for me, it's easiest to find the scapular spine and then get a short axis image of the infraspinatus muscle, and then you'll slide just inferior to that, and you'll usually find the teres minor just beneath. You can use the scapula too. It's going to have two separate fossa there, so you can find your muscles that way. And then once I find those, I'll slide distally, as this video will show, and we can see the large infraspinatus tendon here centrally, and then a little bit more superficially and smaller, that teres minor tendon. And we'll see that it attaches pretty much right where the physis is. So here's a nice short axis image of the teres minor tendon. And then once we localize it with that method, then I'll get my still images here, have a nice long axis image of a normal teres minor tendon, and then again a short axis image here. Now we focus on the posterior glenohumeral joint. Here we can assess the labrum, which is going to be found here. And then we'll have the patient actively rotate the shoulder. And I'll look for labral detachment if there's a tear or signs of internal impingement, especially in these overhead athletes. And neither evident in our case. And then I think this video shows nicely, as he externally rotates his shoulder, the suprascapular vein here engorges with blood, and you don't want to mistake that for a cyst, as a cyst would obviously not change shape. So normal posterior glenohumeral joint, no effusion, no labral tear. And then finally, our last couple landmarks here, the suprascapular and spinal glenoid notches. We'll look for the suprascapular nerve, and actually in this case, we could actually see it. Nice honeycomb fascicular appearance of the nerve there in the suprascapular notch, and then following that down into the spinal glenoid notch. Looks normal in size, and no cyst in either of those notches. So again, normal. All right, so here's my report, the template I use. On the left, you will see demographics that we commonly will try to report. And then I think unique to pediatrics, we put a brief teaching statement here that just documents that the procedure was explained and we got consent to do the scan on the child. And then on the right side, we'll see our findings. And this is going to be from landmark to landmark and use sentence form. And I try to avoid diagnostic terms in this part of the report and really reserve that for the impression. In this patient in particular, everything was read normal except that proximal humeral physis, where we saw some asymmetric widening, periosteal edema, and mild hyperemia on Doppler. And then also very important to report is had localized sonal palpation deep at that physis. And then with all that, we get our impression where we can report that there's sonographic evidence of proximal humeral epiphysiolysis. All right, some take-home points, especially for all of you in busy practices and fellows trying to work on efficiency. So while I think complete shoulder protocols are standard, and I teach that and try to practice that, and this may not be a popular statement, but I think in pediatrics, especially for the shoulder, limited exams can be okay. You can focus on these immature landmarks. I think that's an acceptable practice to do. I think if it's the choice to skip the ultrasound or do a focused exam in a busy clinic, I would choose the focused exam. And then as you get more efficient, obviously you can get through a full protocol. And the reason you can do this, I think, is these diagnoses are often well localized by the patient. We don't see as much referred pain from rotator cuff and labral pathology in kids. So they often come in pointing to the spot. And again, ultrasound can really help us visualize that and help with our physical exam. So some efficiency tips, I think, especially in pediatrics, as you're getting used to doing this, you've got to be quick because kids are impatient and they like to wiggle, and you gotta move quick. So you want to really focus on optimizing your images. So if you're not great at labeling yet, do that later if it slows you down. So that'd be number one. And then one thing that I've really found effective, and always curious to see how others are doing it in their clinics, but what I will do is I'll see my patient. I usually have a 15-minute slot, and if I see point of care ultrasound as a good tool, I will have my medical assistant or athletic trainer do their kind of wrap up of the visit. Maybe it's given a home exercise program or fitting for a brace, get a school excuse, whatever it may be. And I'll move on to the next patient. And then once they're done, they'll move them to the ultrasound room. And then I can quickly go back in afterwards and do my ultrasound scan. So that keeps me moving, keeps clinic flow, more efficient, and kind of avoids those empty rooms of waiting. So that's one tip there. And then I think for kids specifically, a lot of times this will be the first time that they've ever had an ultrasound done. So it can be a little intimidating, especially for the younger kids. So I try to avoid using terms like probe and like to call the transducer more my special camera. I think warm gel can really go a long way. They appreciate that. And I do most of my exams, if not all, lying down because I think that helps reduce movement because otherwise kids are, again, wiggly and moving around. And I know a lot of people like to do their shoulders sitting up, but you may consider trying to do those laying down in kids. And then this is where distractions are very helpful. This is the one time I think screens can truly help. So have a phone, tablet, something to distract them. And I think just above all, one message I wanted to just relay today is don't forget to use ultrasound in the skeletally immature patient, especially in the shoulder. These landmarks listed here and some that we've discussed today are often missing from our protocols. And I think ultrasound can really help confirm some of our diagnoses and often will catch some things that radiographs miss. And I think if nothing else, the families really appreciate us using this in clinic. So one quick last note, if you're interested in this topic, pediatric musculoskeletal ultrasound, and are free later next month, feel free to reach out. We have a pediatric musculoskeletal workshop that we're doing at the PRISM annual meeting in Austin, Texas. And we'll be taking a deeper dive into the upper extremity and looking at shoulder scanning. So again, this might be a good way if you don't have a lot of familiarity with pediatric musculoskeletal ultrasound, finding conferences like this could be helpful. And with that, I'll hopefully get some questions or comments. And then if you got a second and you can take a picture of that QR code, that would take you to an evaluation that I would much appreciate if you could fill that out so I can, continue to try to improve my presentation. So thank you again for the opportunity to talk today, and look forward to taking any questions or hearing some comments.
All right. Well, thank you so much, Drew, for that presentation, especially on a pediatric topic that we don't see too often. So, Drew, I just had actually just a couple of questions. For this apophysitis, you had mentioned using the color Doppler and looking for hyperemia. For the adults wise, we obviously use it quite a bit, for tendinopathies and things like that. And so far, don't have too much of like a set grading system for it. Is there like an objective grading system for this that you guys use in pediatrics, or is it just kind of more whether it's present or not?
Yeah, so I'd say in my practice, it's still a little bit subjective. I know in the rheumatologic world, they do have grading systems where they will look at things like enthesitis with Doppler, but I would, I think be lying if I said I followed that closely and then reported that way. So it's usually for me, it's more subjective, and again, comparing to the contralateral side, because as you know, normal apophyses will be very vascular, and just seeing Doppler doesn't necessarily mean that there's pathology.
And for these cases, are you then typically doing serial scans? Have you found that like helpful to evaluate for like healing and I guess how quickly are you typically seeing those resolve? I mean, obviously I know it probably depends on the severity, but didn't know if that was helpful or whether these ultrasound findings will kind of lag behind like some other imaging.
Yeah, I try to do serial scanning when I can. I think if nothing else, the families appreciate it. Um, but yeah, I think you can see some of these issues resolve with time. I do think there probably is a lag behind kind of clinical healing, what you're seeing on your physical exam. But I'll look for the periosteal swelling to go down. I'll look for the hyperemia to be less pronounced. I think some of the physeal widening, apophyseal widening, fragmentation, that tends to linger for a bit, and I don't always see that go away. But I will try to do some serial scanning when I can.
All right. And then actually one last question from me, just from the pediatric end too. For these folks, you had one of those cases, the coracoid case, where you ended up doing an injection.
Mm.
So I guess for some of these kids with still open growth plates, are the majority of these diagnostic, or do you occasionally do steroids, or is there other injectates that you consider using, such as Toradol, or how do you usually approach that?
Yeah, that one specific case that I presented, that was just a diagnostic injection. So we just used some, I think, lidocaine or ropivacaine. So yeah, I would say very rarely do I ever inject the apophysis or any of these other ossification centers for therapeutic purposes. There'll be a rare instance where I will try a steroid, just kind of around superficial to the growth center. It's those recalcitrant cases that have tried everything else. I do think there's some reasonable literature to support prolotherapy for things like Osgood-Schlatter disease. I know there's a lot of folks that maybe try platelet-rich plasma or PRP as well. Um, but I would say most of the time in my practice, it's mostly just doing diagnostic injections, if even that. Because as you know, most of the time we're pretty fortunate in pediatrics. A lot of times these apophyseal injuries, physeal injuries heal very well conservatively.
Nice. All right. Well, otherwise than that, just had I don't think any more questions in the chat, but just everyone said great presentation and thanks again, Drew. So unless anyone else has any other questions, that will conclude today's presentations, and we'll conclude this year's faculty presentations. Just logistics-wise, then we'll go ahead and start up in January for the sports medicine fellow presentations. So if you're watching this and you're interested, definitely reach out to us if you're a sports medicine fellow this year and want to present. So thanks again.
Thank you.